thank everybody at Datum and Dentsply Sirona for offering me the opportunity to speak with everyone today. As Chen said, I'm a periodontist in private practice and have been practicing for some time, since 1984. And with that comes a lot of experience, a few successes, a few bumps and bruises. And hopefully through that, I can share some experience that will be helpful for everybody. And we're here to talk about protecting crestal bone around the dental implants we place. So, we're all striving to deliver a durable, healthy, and aesthetic implant treatment for our patients. And in that process, in that pursuit, we're all hoping to develop protocols in our office that are predictable, repeatable treatments so that we can feel confident offering these treatments to our patients. And often, many of these cases are going to require some form of augmentation of hard or soft tissues, some sort of augmentation. And whether it's before we place the implants or while we're placing implants, we're trying to establish these healthy environments. So, when you look at a case like this happens to be a case way back from June of 2014. And we removed a blown out root canal treated central incisor. We were left with, we'll call it 2.5, maybe 3 walls. And back then, in my practice, the usual go-to was particulate bone graft covered by a collagen membrane. And when you look at the before and after on a case like this, quite honestly, I was very happy. I was more than ecstatic to have good fill, good solid what appeared bone, contours that blended in very nicely with the neighboring teeth. And I think most people would be happy with that. And when we looked at the result, given what we were starting with, it was a half decent result, right? I mean, sure, a few seams in the tissue that we could fix, but overall, the tissues looked healthy, the implant looked stable, and patting ourselves on the back, good job, good job. And then, a few years later, when you look at a case like this, I start to look at it a little more carefully, and I realize that over 50% of this side is grafted bone. And I start to wonder, how confident should I feel about a result like this? Why do I worry? Well, I'm concerned that will this perform long term for this patient? Will this marginal bone, the marginal bone and the supporting bone hold up over time? Especially when you realize how much of the tissues around the implant are grafted. And the reason that I worry about it is our cases like this. This is Stan. Now, Stan had an implant placed, we'll say 15 years ago by my partner. He removed a molar, grafted it with particulate bone, covered it with a membrane. Back then, my partner was leaving a lot of the membrane exposed. And then about 8 years after that, 10 years after that, the patients referred back to me, can you treat this defect? And so when you look at a defect like this, you start to take a look at the shape of it and you're going, this is kind of similar to the dimensions of the original extraction site. And when you compare the walls of the original socket to the walls of the defect, it's looking quite similar actually. And so then you wonder, okay, why is the bone superficially being resorbed in a shape similar to the original socket? How much of this is related to early exposure of the graft material at the time of grafting? And if my partner left this membrane exposed, would it have mattered what type of membrane he used? And how would that have affected the behavior of the underlying graft material? Alternatively, is this, am I missing the boat? Is this a reaction to grafted bone to crestal stresses? And how often does it happen? And the truth is, it happens pretty often. In fact, here's a case of mine, and you can see the difference in the density of the grafted site around the implant. And then I've been in practice since '84. So when I first opened the practice I'm in '86, I was a young guy. I barely needed to shave. And now I'm the guy with the gray hairs on my beard. And so I'm starting to get cases from other dentists putting in implants and other surgeons actually. And we're seeing a lot of similar types of defects form. So is this graft failure versus periimplantitis on its own? Is it a histocompatibility issue? Is there a problem with primary closure? Should these grafts behave differently if we covered them? All sorts of questions. And I know we're not the only ones in Chicago with this, because Dr. Shatta published a couple of years ago in JOMI a retrospective study where he looked at 540 implants. And he looked at how many implants were showing bone loss. So in this study, he said 25% of the sites had periimplantitis, and he defined that by more than physiologic remodeling. And he used the second thread of the implant as his threshold. I think that's a little loose. And so maybe a higher percentage of the implants were having some sort of pathologic bone loss. And then he assessed all sorts of factors: the shape of the bone loss, was it vertical, horizontal, and tried to connect that with other variables, such as where it was placed, how long it's been in function, whether it was grafted. And what he found out was that combined lesions, either vertical bone loss alone or bone loss with horizontal defects, had an odds ratio of 2.5 and 2/3 to 1 that these were grafted sites. So grafted sites were behaving more poorly than the other sites. And so that fits in with the other studies that show that, there's somewhere between 20-30% incidence of periimplantitis. And we know this is a problem that's not going to go away. So when you look at periimplant disease and periimplant and implant failures, you can break it into early concerns and later concerns. And even in early concerns, we starting to understand that periodontitis is a factor, smoking, of course, and way at the bottom you see wide implants. And so, why wide implants? Is it because the implants are wide and there's a difference in instrumentation, or is this about there's less bone surrounding the implant the wider the implant? All sorts of questions. And then when you look at later failures, you can't isolate marginal bone resorption, because that's going to be the first step in progressive bone loss for these implants that have later problems. This is where the battle's going to be fought. And so normally in a practice, this is an old external hexed implant. It wasn't uncommon to see this kind of remodeling where, first it's the implant's buried, then you see remodeling to the top of the implant. And by the time the implant's restored, we have bone loss. This would have been considered physiologic in Dr. Shatta's paper, even though we have some other problems going on. So is this early marginal bone loss a prelude to periimplantitis? But the questions keep coming, because this is actually a Brånemark implant placed in 1991 by me. It was early in my trajectory with implants. The patient had pain. I actually, 2 days after placing these implants, raised them up about 1.5 millimeters because the patient had pain and I did not know what to do. But 2003, a little bit of bone remodeling. But by 15 years later, it doesn't appear to be progressive. So now I'm really confused, because some areas are progressing and others aren't, in spite of the external hex attachment, in spite of a thin biotype, and so on. But we're starting to identify some factors that we can correlate to progressive bone loss. We used to think that the denser the bone, the better. And now we're finding out that denser bone may be connected to lower stability, that type 1 bone is actually less stable than other types of bone, and that the lowest marginal bone loss around implants is actually associated with type 4 bone. So bone quality matters. Bone thickness, there's no surprise that when you look at the sites that have thin buccal plates, we are going to see more remodeling, more resorption compared to the sites with the thicker grafts. And that doesn't matter whether you put an implant in or not. The implants don't impact the remodeling. What we do know is that when you place an implant, the buccal bone thickness matters. If you have greater than 1.5 millimeters, you're going to expect reasonable stability to the buccal gingiva. Some studies say 2 millimeters. And that buccal bone thickness less than between, we'll say, 0.5 millimeter and 1.5 millimeters, these implants are going to show recession. So bone thickness can impact gingival trajectory. And so it's no surprise we're all trying to thicken the biotype. We're all trying to thicken the hard tissues around our implants to prevent this kind of problem. It makes perfect sense why we want to provide the implants as much protection as we can. What about the other way around? Well, when we look at assessing early bone loss, we know that the thicker the tissue that we have covering a healing implant site, the better. And Dr. Linkevicius in 2014 and subsequent studies has shown by him and others that the thicker the tissue, the more stable that bone is going to be around an implant. And we also know through a number of studies that when you have a thinner tissue thickness, it's just going to have a greater chance of developing recession. So anytime your tissues are less than 2 millimeters or so thick, expect a little bit of marginal bone loss and a little bit of recession. So here's another case that I put in 2009. It was a threaded internal connection, and I was really happy. The dentist delivered a beautiful crown on this right central incisor. In 2009, patient comes back 5 years later, and we see exposure of the zirconia abutment. And it's disappointing. And then if you take a closer look around, there's some tissue changes around a number of other teeth. The left canine, the left lateral, they're starting to show a little bit of recession. There seems to be a change in the thickness of the tissue. And so we know that with patients over time, it's not uncommon to see some recession develop, getting a little long in the tooth, right? And recession in life happens. So then the question comes up, are we arrogant? Is it arrogant to think that we can prevent this? Can we beat nature? Can we beat nature in time? Stefanini in 2016 showed that, placing a soft tissue graft, a connective tissue graft around implants can thicken both vertically and horizontally, was able to prevent recession up to 3 years in her study. So the tissues matter, right? What about how we place the implants? Well, if we take a look at some of the choices we have, one of them is depth of placement. And we do know that some studies are suggesting that the depth of placement impacts the bone levels. And depending on the design of the implant, we've seen studies that show that implants placed equicrestal, right at the level of the crest, show less bone loss than those that are sunk in. And we can pick from what? I think it's over 200, 250 implant options out there. We have a lot of choices on what kind of implant we're going to place in our patients. And within that design, there are multiple decisions, right? Diameter. And we know that there's a growing trend toward maybe placing some thinner implants because a thinner implant means a thicker level of tissue around the implant. And we're seeing lower mean peri-implant marginal bone loss with the smaller diameter implants. And if we're not going to compromise managers of stress, we're better off with a thinner implant. What about smooth versus rough? Well, every implant system has their design, and some systems put a polished collar because they don't want to have an exposed rough surface. Others use a rough surface to prevent that bony change. But I think what we can say is that implant design will impact how comfortable you are in the depth of placement. And maybe implants that have a polished collar may have more bone loss when you sink them. And so again, as we extend the considerations of design, micro threads, platform switch, flared implants, we've learned some more things. Both Lee in 2007 and Song later, a couple of years later, have shown that micro threads on the Astra implant prevented marginal bone loss compared to the implants without micro threads. So managing those crestal stresses seems to play a factor. And as late as this year, Michael Norton showed that he compared the behavior of maintaining the marginal bone around Astrotech OsseoSpeed implants and the Straumann SLA and Nobel implants, and they perform pretty close. I mean, the Astrotech seemed to come out a little bit on top, but microthreads, platform switching, and a roughened surface do make a difference. And then we have choices. So, you know, people think it's so easy to put the implants, and we have all sorts of many choices during a surgery. And one of them includes, are we going to bury the implant or not? And, you know, in my office, we are more likely to bury implants if the bone is particularly soft. But Park showed that single stage protocols, non-submerged implants show less crestal bone loss when all things are equal. Although we know that with smokers, it may be a higher risk factor to perform a single stage protocol for implant placement. But overall, leaving the implants exposed reduces the risk of marginal bone loss. No matter what we do, we know there's going to be remodeling. And perhaps some of that has to do with how the body protects itself. Remember that teeth are the only organ that starts in the bone and passes through and out into the oral environment. We don't have any other organ that has this kind of challenge, and so the body has to form a protective seal. Bone is going to remodel. On top of that, if you compare the tissues around the tooth on the left side of this and this diagram compared to the right side where an implant is, you know, we have a different anatomy. We have a different histology. We know that the collagen fibers insert into the root surface. These Sharpie fibers form a very effective seal along with the junctional epithelium to the challenges in the oral cavity, where the collagen fibers around an implant are parallel. They just can't create the same kind of seal and resistance. And we all have learned that with how cement behaves around an implant. And the vasculature is different. When you take away that periodontal ligament that exists between tooth and bone, we are really limiting the source of blood supply, not only for maintenance of tissue, but for wound healing. So that's what's happening deeper. When you look at the epithelium, it's the junctional epithelium. Here it's listed as the peri-implant epithelium, but it's the junctional epithelium that the body's attempting to seal itself off from the outside world. And so when you have the break in that integrity, so whether it's a buried implant and you're removing a cover screw and delivering an abutment, or you're removing a healing abutment and delivering another abutment, it sets off an alarm. That interruption in the implant abutment surface, that implant abutment interface sets off a series of events where the body wants to protect itself and it wants to seal itself off from any challenges from the outside world. So it's forming this junctional epithelium, and the bone starts to remodel. If it's not platform switched, you're going to see a lot more remodeling, and this bone goes lower and lower in order to create this effective seal. And just how much remodeling occurs depends on biotype or phenotype, implant design, and the platform switch design. How much can we tolerate is not clear. So we know that no matter what, the body's going to remodel the tissues around here. And then on top of that, there's other challenges. So there was a paper, Galindo Moreno and his group in 2014 looked retrospectively at a number of implants placed, all with the same protocol of abutment level dentistry. So it was abutment level, and it had screw retained design. So that's great. But what they found was that how tall the abutment was had a significant impact on whether there was going to be bone remodeling. And the shorter the abutment, the more likely you were going to develop peri-implant bone loss, independent of the tissue thickness. And then the same group 4 years later showed that whether now they're using cement retained crowns and bridges, and the platform switch helped, but if you had tissues less than 2 millimeters, you knew you were going to have some bone remodeling. So even if you go back to my practice here, this is just an example of a common finding we saw. These are immediate fixed hybrids. This was with the Biomet system, placed in 2013. We did some with this system until about 2015. And this is a pretty illuminating slide, because on the left here and on the right here, you have straight abutments. And right next to it, you have these angle correcting abutments at 17 degrees. And the way these abutments are designed, they're one piece. They flare out pretty quickly to provide strength to the abutment. But look at the bone remodeling that occurs around where these abutments flare out. So think about it, immediate fixed hybrids, you're placing a permanent abutment the day of surgery. There's no implant abutment interface interruption. There's no removing of components at the implant level. And yet the body wants to remodel around these abutments with this close proximity of abutment to bone. So now we're thinking biologic width, right? And if you compare it to other systems like the SmartFix system, this is also an angle correcting abutment, but because it's slender, because it doesn't impinge on the bone, it seems like the tissues tolerate this design much more easily. In either case, there's no interruption of the interface. It's a narrow emergence profile here, and the tissues seem to tolerate it better. So biologic width is clearly showing its sensitivity here, and I think we can extend that awareness, that concern to other implant applications, whether it's single tooth or partially edentulous cases. And so we're talking about implant design, we're talking about abutment height, abutment emergence profile. What about the crown profile? So here's an implant we placed. It looked like a pretty straightforward case. The bone's a little higher on the mesial than the distal. It comes time to expose it. I put a healing abutment on. I think everything's going fine. And I really didn't pay attention. You know, this dentist really liked me to place a wide healing abutment so he could have a nice emergence profile and reduce the chances of a black triangle or food impaction. And I didn't really pay attention to the proximity of the healing abutment to the bone. And by the time he restored it following that contour, you can see the body didn't like it. And just to review, this was a screw retained crown with good occlusion, machine to machine parts, and yet dentist is doing everything right, and yet we're having this bone remodeling. And clinically, when we opened it up, there was a lot of bone loss, and we're not too long out of the gates. This is in the first year, so we had to clean it out, graft it, repair it, and change the contours of the crown. So now we're really seeing, for some patients, or if not all, a sensitivity to how we design that emergence profile, both with the abutment and the crown. Fortunately, this stayed stable over the past 6 years after repair. But you can see this over contoured crown, how it can create inflammation. It's going to favor, accumulation of bacteria, biofilm, and it really makes it a lot harder for patients and during the hygiene appointments to control the bacteria. Fortunately, we were able to correct this. I got into a fight with this dentist because he was sure he'd done everything right, and it took a while to explain that that was the wrong size abutment. But even in other cases, I also have a concern by extension to these tie bases that are kind of one size fits all, and not every case is created equally. And so I do think we have to have some awareness on how we shape the abutment and how it relates to the surrounding bone. I mean, this is a double jeopardy, right? We have no platform switch, so we know we're going to get remodeling, and then on top of that, we have an over-contoured tie base. So if we were looking for guidelines, I'm not sure what that tolerance is for a given site, and how we would measure that. And one more discussion on this area of biologic width. When I put this implant in, and I'm a bigger fan of some implant systems than another, and I looked at the on the right is the torque test image, and I see bone loss, and I'm like, oh, that's just a bad implant. and or maybe the tissue was too thin, like Dr. Linkevicius says, we have to protect the healing with thicker tissue. So is it the implant? Is it the overlying tissue? Was it a graft failure? And then I start to look at how close I place that healing abutment at the time of surgery, and maybe this is iatrogenic actually, and maybe this is a biologic width issue from the get-go. So let's switch from that to osseous architecture. Um, I don't know if you remember the early on we talked about a case where I placed a Brånemark implant in 1991, and it had relative stable bone in spite of exposed threads. This is the same patient, Esther, who's been in our practice for what's that, 25 years or more, and she was very funny. She needed to lose all her teeth, and she insisted on hanging on to two. She goes, do I have to lose this one? I really don't want to lose it. I go, it's just a stub. She goes, I don't want to lose it. So we caved in, the dentist and I, and we created an overdenture that fit over two bars. And honestly, it worked quite well. And I think the fact that these implants were splinted, especially under a maxillary overdenture, was critical. And this was in spite of having an ultra thin architecture. There is bone here, it's just very, very thin. And it's quite remarkable that in spite of a thin osseous architecture, these implants have survived for 25 years. And then you look, I'm sorry, 20 years. And then you look at a case like this. This case was a different case. It had a bar going around from from the upper right to the upper left. Everything's going fine. It's over 10 years stable. And then for some reason, the dentist removed the bar. I have a feeling he dropped it. It bent. He couldn't get it back on. So as a less expensive solution, he put on locators. And all of a sudden, the bone starts deteriorating after 10 years of stability. And so when we look at the factors that impact marginal bone, now we got to throw in biomechanical stresses, occlusal stresses, and some designs matter for certain applications. Certainly, we can say there's a lot of literature that freestanding implants under a maxillary denture or overdenture are at risk, and we're much better off to control those forces by splinting them. On top of everything else, nature happens, right? We know when we take a tooth out, there's going to be remodeling. All the studies show there is a shrinkage in the atrophic process and the remodeling of the bone. We lose horizontal dimension, mostly from the fascial buccal, and we lose vertical dimension. And I repeat, implants don't matter. The fact that we place implants in, we still see this bone remodeling. You know, when I trained in 1987 on the Brånemark system, we were told implants stabilize the bone. It will stop bone loss. It's just not true. Placing titanium in a edentulous area does not prevent the atrophic process. It's just a fact of life. So we've gone over many factors that contribute or are at least a consideration for how the bone and the tissues behave around an implant. What can we do? What kind of strategies for prevention and protection of the marginal bone can we employ? Well, let's start out with our goals, right? We want to have a robust hard tissue, and we want to have a robust soft tissue environment for our implants. That's not new news. And there are plenty of studies showing, whether it's in the aesthetic zone or elsewhere, that whether it's an immediate implant placement or delayed implant placement, placing materials around an implant and thickening the soft tissue seem to be a beneficial step in the design and treatment of our implant areas. But more often than not, we're using membranes to protect our bone grafts. I'd like to start there. So when we look at membranes, we have choices, right? There are resorbable materials, there are non-resorbable materials. What would we like? We want a membrane that's going to last long and protect the graft. We want it to be biocompatible. We want it to get along with the tissues and not create other problems. And what I mean by that is we don't want to elicit a tissue reaction when we place these membranes. It would be nice not to have to remove it, and that kind of moves us away from the non-resorbable membranes. And ultimately, the point is we wanted to optimize the outcome of the grafting, both in volume and in quality. So if we look at the resorbable materials, we have both fast and slow materials. And all the way on the left, the fastest resorb membranes, collagen membranes, are those that are cross-linked. I just came back from Europe for some talks, and I learned that over there it's very, very popular to use BioGuide, and they like it because it's a little stretchy. You can tack it, but it's not cross-linked, and it is resorbed very, very quickly. So pluses and minuses there. And as you extend to the slower and slower resorb membranes, most of the collagen membranes that are out there have to be, well, all the membranes have collagen that's cross-linked. And what we know is the more cross-linkage is accomplished in the process of the manufacturing, the more cross-linking, the better, the longer it's going to last. The problem is most systems use glutaraldehyde to facilitate this cross-linking process. And so there's this balance that the manufacturers have to find between, they want this material to last long, but if they use too much glutaraldehyde, there is a residue in the membrane. And so when that membrane is broken down in the body, it leads to a toxic reaction, a tissue reaction, right? But all the way on the right, we have this newer technology over the past, we'll say 20 years, where collagen can be cross-linked with a Glymatrix technology, which is a sugar-based, ribose-based process that leads to a much longer lasting membrane because it's got a much higher degree of cross-linking without all the negative consequences of using glutaraldehyde. How do they do it? So they collect porcine tendons, and they once they retrieve it, they degrade it chemically and enzymatically to develop collagen monomers. We'll call it regenerative jello. And these collagen monomers have pig-specific, species-specific peptides as part of the protein. That has to be removed. So they have found a way to cleave off and purify these collagen monomers to get rid of the species-specific portion. And now you can repolymerize it into collagen fibers that are now cross-linked with this sugar-based, this ribose-based Glymatrix technology. And what you're able to produce is this extremely durable, extremely long-lasting OSSIX+ membrane. The cool thing about this membrane is it ossifies. It turns into bone. So back in my first experience was in 2002. This is a case from 2003. When OSSIX was launched in 2001, it was made from cow tendons, cow material, and there was a concern in the early 2000s with mad cow disease, so it was taken off the market. They retooled, and they came out in 2006 with OSSIX+, which is a porcine-based product. And so this case is from 2003. At the time, we removed the lateral incisor, and I was going to do an immediate implant placement, but the dehiscence was pretty big. There was a fenestration at the apex, and I said, okay, we're gonna graft this. So I used our OSSIX membrane, and we just positioned the tissue back to its original position. There was no advancement for primary coverage, and I really didn't know what I was accomplishing at the time. In 2003, I really didn't understand the biology at all. And so until much later, I couldn't appreciate the fact that we were able to create this robust environment for implants, even though I left the membrane exposed. So earlier I asked, how important is the membrane in protecting the bone graft? It's really important. And there was a very simple, clever study performed in 2010 by Klinger's group in Israel. And I think they started with about 20 subjects. 12 of them finished the study that lasted all of, I think, 10 days. They put periodontal dressing on the buccal of the posterior teeth with 3 different membranes. They placed one that had glutaraldehyde cross-linking, the Biomen, they had the BioGuide, which is not cross-linked, and the Ossix Plus. And they left it there for 10 days, and 12 of the subjects returned. And what they found was consistently what you see here on the lower right. Only the Ossix Plus remained for 10 days relatively intact. And that's certainly consistent with my experience and other studies. So this is a simple posterior molar extraction, a good way to start with Ossix Plus. When it comes out of packaging, it's dry, it comes in 3 sizes. You trim it to size. It's not a bad idea to trim it a little extra because it's going to expand once you hydrate it with sterile saline. And this was a case done with particulate bone graft covered by the Ossix Plus membrane. And we suture it, and notice a couple things. We left this membrane exposed, and notice 2 things. 2 weeks later, the flaps are closer together. The sutures didn't get tighter. I'm going to assume the graft, settled in and allowed for this, but you can see that the tissues really like the healing over the membrane. And if you look clearly between the flaps, the membrane, the Ossix Plus looks brand new. So even at 14 days, at 2 weeks, it's still holding its own. And then if you look 3.5 months later, take a look at the healing. The tissue's thick, the tissue's grown over the Ossix Plus exposed area. And when you open it up to place the implant, no surprises. The membrane beneath the flap is very much intact. It almost looks brand new. Where it was exposed, of course, that's going to resorb. That's going to go away. But wherever it was covered under primary closure, the membrane remains. And then when you place the implant 3 months later, look at the tissue thickness. We really have a tissue-friendly material that we're working with. And we had a good result. This was fairly typical for extractions with Ossix Plus and then implant placement. But even in a sinus lift case, when we re-entered 6 months later, not to show you the sinus lift, but you can see that there's plenty of membrane remaining even at 6 months when it's covered up. And when the membrane is placed inadvertently over the implant cover screw, it will ossify. And so this material is very biocompatible. These sites heal very predictably, and they will ossify. So that's it about membranes. What about the bone grafts we place underneath? Well, for many practices, we have a lot of choices from autograft. And in my practice, we've used a combination of autograft, allograft, and occasionally xenograft until recently when we started using these new products that are based on that GlyMatrix technology. But let's take a look. I mean, particulate bone grafts are very popular, especially in site development or site preservation. And when you look at the healing closely, this is a freeze-dried bone allograft. I have more questions. So this was a 3-rooted maxillary molar. And when you look, different areas behave very, very differently. We see the highest degree of trabeculation that mimics neighboring non-grafted areas along the mesial, and yet further down toward the crest, the appearance of the bone seems more granular and less mature. It looks like it's still graft. And then when you look to the distal, it all looks granular. And I can't give you a concrete reason. Did I decorticate more aggressively in one area? Possibly. Did the depth of the graft material away from the oral environment matter? Possibly. Did the type of membrane matter? I'm sure. But even when you look where the battles fought, where is that? Right at the crest, you can see a lower density of in the appearance of the bone graft material. So constantly trying to improve. What are we looking for? Better materials that will behave better. And we walk through the process that creates Ossix Plus. And about 3 years ago, Datum came out with Ossix Bone. Same concept, porcine collagen going through the GlyMatrix cross-linking process. And this is what it looks like in packaging. It's a dry, almost chalky like sponge. It's brittle. And it has to be, in contrast to the OSSIX Plus membrane, which is moistened with sterile saline, it is best to moisten this OSSIX bone. It should be called OSSIX Pro bone because it's not a bone yet, right? But this bony scaffolding should be moistened with the patient's blood. But given this Glymatrix technology, can we encourage a formation of a more native type bone? Well, think about it. It's prion free. There's still no species specific peptide, so it's very compatible in the body of the patient. The body recognizes this material as its own. We've used the datum has used a Glymatrix technology, so it's a highly cross-linked, long-lasting scaffolding for the cells, and it ossifies. It ossifies very, very well. Why is that? Well, take a look at this. Engineering is so cool. You can see these channels, and so when they manufacture the OSSIX bone cubes, these channels are there that allow for cells to grow in very, very rapidly. And so when you're managing this material, the biggest advice I can give you is don't compress it, never squeeze it, never smush it in, because you're going to be collapsing and compressing these channels that are so critical to the healing. Over the past several years, just like I said, we want to create this robust, thicker environment for our implants. There's been a strong emphasis on volume. And we want the volume, but we don't want to forfeit the function of the bone. So Dr. Yuval Zuberi in 2007 had a very clever study where he took dog mandibles and he created L-shaped defects mimicking an atrophic posterior mandible. He grafted half the sites with BioOS collagen, the other half of the sites with OSSIX bone, and both sites were covered with a OSSIX Plus membrane and allowed to heal for 6 months. And if you follow the healing on the OSSIX, on the BioOS, at least in this sample, it looks like the BioOS, it kind of settles in. It has not bad volume, right? But it's settling in. And if you look at the OSSIX bone, it seems to be able to hold its volume quite well, even though it's not a hard material. So I think we have to start adjusting our mindset and then look at the histology on this. Even if the volume of the defect repairs was identical, all those orange spots you're seeing on the left are the BioOS collagen particles, meaning all of those orange spots are non-vital remnants of the graft that can't contribute to healing. They can't behave as vital native bone, resilient tissue that can handle the stresses of the oral cavity, whether it's biomechanical, inflammatory, bacterial challenges. And it reminds me of a talk I saw of Dr. Nieva, who I believe is speaking in a couple of weeks for Datum. And he took split socket. He took out molars, and in one socket put in BioOS, and the other he put in freeze-dried bone. And in both, there was a high percentage of non-vital, I call them wood chips, residual bone graft material. And with the DBBM, the BioOS, it was up to 85% non-vital material. So when we're looking to develop healthy tissues to protect the implant, if we can form more native healthy bone, that's the tissue that's going to help protect the implant. So when we look at OSSIX bone, the consequence of this technology is 100% of the patient's bone. There's no residue, there's no bone chips, wood chips surrounding the implant. This is actually a molar extracted. It's an excellent way to start with OSSIX bone and get used to the material. You can moisten it and section it, place it in. It can crumble in when you place it into the socket. I like to flap my cases to inspect for defects and any fenestrations, dehiscence. So I always cover it with a membrane. And again, you can see how much of that membrane is exposed. Now we're using the OSSIX Plus over the OSSIX bone. And at 3 months healing, the CBCT shows nice fill, nice preservation of the architecture. And at 4 months, this is actually a really good, and not always, we don't always get this mature looking cortical appearance after 4 months, but these sites heal very predictably. And what I mean, you don't always get this is every patient's different. Some have a different biology, some are more compliant, and some chew where they shouldn't chew. But you're going to get different degrees of healing when you use Ossex bone. And some areas are going to look more developed than others. So this is what it looks like in many cases. At 4 months, you'll still see some residual Ossex bone undergoing ossification, but eventually you're going to see this development of a more mature, solid bone. Um, and at 12 months, certainly, there's going to be an extremely high degree of ossification of Ossex bone. It always gets there. So what's the best time to re-enter to place an implant? It's going to differ from doctor to doctor. I don't think you have to wait for complete ossification. And so for molar sites, we're on a pretty routine basis coming back at 4 months. So that's Ossex bone and its potential. I'd like to demonstrate a little more about the Ossex bone. So in the aesthetic zone where we have our greater challenges, here's a patient who had severe resorption on an upper right central, and we took the tooth out. Very thick biotype. It's a nice case. This is not the kind of case you start using Ossex bone, but it was a nice case for a flapless immediate implant placement, positioning that implant palatally to allow for a greater gap. We gently place our Ossex bone. You can see it still crumbles. I'm not going to compress it. Cover it. This case, we use a slice of thick perioderm slipped in between the gingiva and the healing abutment. That's what it looks like early in healing. And that Ossex bone is going to behave very well. This is a technique sensitive procedure, but this is the final result. This is about 1.5 years later. Again, this patient had a thick biotype. So we had a few things going our way, but case after case after case with different patients, different biotypes, we are able to form Ossex bone. So I like showing these cases because they show the potential of the Ossex bone. And quite honestly, we've been blessed with fairly consistent, I think, aesthetic results where the flapless technique allows for less scarring of the soft tissue. And ultimately, all these sites develop good surrounding bone. What about without four walls? What is the potential of Ossex bone in sites with significant defects? So we know that the greater the defect, the more chance you are going to have of developing recession around an implant if you place the implant into that site immediately. Remember this case from 2014 we opened with? I don't know how you would treat it now. I think most people would graft this, develop it, and come back. But what are you going to put in there? And now I'm triple thinking about what I'm going to put in there. And I want to make sure I put something in that's going to lead to the formation of vital tissue, not only in good volume, but in function. And going back to Dr. Zuberi's talk, we're going to try to create something that has 100% or is close to 100% of the patient's native bone, so that we have something that is resilient and that can react and withstand the challenges of normal daily function. But what are the limits to this material when placing an implant into a socket with facial defects? Think about that. We've been taught over the years in my periodontal program for bone grafting, it was all about blood supply. It's all about how narrow the defect is and how close are the walls to provide nourishment and cells for wound healing. Will this kind of technology work in a larger defect when the implant's in the way of the blood supply? So let's go back. I pressed the wrong way. Here we are. To answer that question, to help me answer that question, I looked at another case. This was a case of a second molar with a large periapical infection. The infection's kind of performing its own sinus lift. I'm thinking about how the Ossex bone heals with channels and cells migrating in. And then I placed Ossex bone, and you can see very clearly the shape of the Ossex bone in these CBCT images. And at 5 months, it doesn't look at all like there's this wave of density of bone from the lateral borders. It almost looks like it's healing best where the ossix bone is, and pretty homogeneous throughout the ossix bone material. So now I'm starting to picture this healing like salt crystallizes, or where you have different nidus of crystallization, and wherever the cells are, they're going to heal independently of where the blood supply is. I actually, when I did this posterior case, I tree-fined it out. I sent it to the local pathologist, and he sent back these images where it showed very evenly scattered areas of ossification and bone, new bone formation throughout the sample. So when you look at this case, it healed well, but not from the sides in. It seemed to heal pretty uniformly, at least at the times I looked at the case, pretty uniformly throughout the defect. Let's take that concept of pretty even healing and apply to a case in the anterior with the defect. So here's a case with severe resorption. We're going to lose the central. There is already a ponic on the lateral side. And we remove this tooth. And I don't know how people would approach this. My guess is most people would want to develop this site prior to placing an implant. I didn't. I placed the implant. You can see a pretty significant exposure of threads, and here's more of a incisal view. You can see we've positioned this for a nice size gap, but we have a large defect. So we placed our ossix bone. That's not a pretty picture, but we weren't going to compress it to make it all uniform and smooth. And we have the ossix plus membrane ready to be positioned and tucked under the surrounding tissues and closed up. We do have some exposed membrane, and you can see where the membrane's healing, still present at 4 weeks, and we were able to form some nice bone. And clinically, we had good tissue height, actually better than what we started with. So something's here. That I do think this ossix bone has a different mechanism of healing, less dependent on immediate blood supply. It has to be in contact with bone. It has to be in contact with bone, but I do think that it has a different dynamic in the healing. And so when you start asking the limits of what you can and can't accomplish, there are limits to everything. And um, there are cases you just have to say no to. But I think when you think of cases like this, or smaller defects, there is potential where the ossix bone performs quite well. And briefly, here's another one where we had a premolar. It's hard to appreciate. You had about 3 millimeters of bone thickness from the implant to the outer walls. We took a nice size of ossix bone and wedged it in gently. Got a little excited with the ossix plus membrane. But we were able to preserve good tissue height, good bone fill, and even on imaging, you can see the thickness of the bone buccal to the implant and how nicely this works in spite of the fact that some of the blood supply is taken away by the presence of the implant. Well, so let's move away from grafting, and what other factors do we have to talk about? Well, depth of placement, we talked about it. Here's a guy who used to breathe over my shoulder. The dentist wanted, he was so specific. He always wanted to use external hex until he retired. He liked machine to machine parts, white occlusion, no cement, and he held the bone. But you see how deeply these implants were placed so he could get his emergence profile. And in the aesthetic zone, we're often, to accomplish the 3-2 rule of sinking implants beyond the tissue, we are forced to sink implants in very, very deeply, right? And I worry about these cases because there's a marginal bone height discrepancy with the neighboring teeth. I think these can be a challenge for instrumentation, for hygiene. There's a potential for future inflammation as these sites get populated by bacteria. I just think that there's a higher risk for these implants in general. And there's going to be this discrepancy. So we know we have limited choices. When you put an implant in, there's going to be remodeling. The bone's going to go away, and we can't leave exposed threads. So now we have to sink the implant in, right? We can't leave these exposed threads. So now we have to sink it in so we can have the, the facial aspect of the implant 3 millimeters below the gingival zenith, and we end up with this deeply seated implant. Wouldn't it be nice if we had another choice? Well, we do, and that's this Astra Tech Profile EV implant, which is a sloped prosthetic surface. And it really, when you talk about all the factors that impact our wound healing and long-term tissue stability, I think this is an incredibly overlooked implant. I don't know why it doesn't have more traction. There have been a few studies, this is just one of a few, that show that the gingiva actually increases when you evaluate the wound healing at 1 year and 2 years out, as opposed to shrinkage. On average, you're getting a gain in the tissue dimensions and thickness. And whether it's the anterior or the posterior, I can show you case after case. This is our workhorse in our practice. We use profiles all the time, both anterior and posteriorly. It just continues to perform at an extremely predictable way and with excellent tissue response. So you're not faced with, well, do I leave the implant a little bit high and graft around here, or do I sink it and leave this lip that I have to shape the healing, the healing abutment and the abutment up and over this bone on the mesial. You don't have as many challenges there, and you don't have to sink this implant more. You just have to change it to a profile, uh, which allows you more preservation of the marginal bone and often less grafting. So we're using it more and more. Implant designs matter. What about the soft tissue? We touched on that earlier. We know that areas that lack attached keratinized mucosa are going to have more recession. They're going to have more interproximal bone loss and periimplantitis. We also touched on Dr. Linkevicius's studies that tissue thickness over healing implant sites matter. So for a long time, we've been using allograft or autograft to thicken the tissue. Here, I took a little biopsy punch to put it over the implant because this was a sloped surface and a profile is not available in the narrower diameter. So we just put that over there so the bone doesn't grow over the implant. And then we cover it with perioderm, which is this thicker, this is the thicker version of perioderm, and it helps create that 2 millimeters or more of soft tissue overlying the healing implant. And it heals well. And there was some remodeling, but we were able to get a reasonable result. But is there some, I'm pretty happy with the result. Is there something that's better? What if we could not only increase the soft tissue, but the hard tissue? So we've talked about two products so far from Datum, and the Ossix Plus membrane and the Ossix bone material. There's a third one, Volumax. And when I first was introduced to this, honestly, I had no idea what to do with it. What is it? It is a 2 millimeter thick, less dense than the Ossix Plus membrane. It actually has 3 layers. If you look carefully, there's a slightly more dense layer on the outside of each side, and then the inside's a little softer, a little less dense, looser collagen arrangement. But as material and information came out, the uses started to become more clear. Here's a publication from Dr. Avila Ortiz out of the University of Iowa in 2018. And he used it as his membrane to cover a bone graft on the buccal, but he happened to extend the membrane without graft over the cover screw. And when the implant healed and he tissue punched it, he sent that punch into the pathologist. And what did he see? He saw about 2/3 of the tissue was really dense. There seemed to be a thicker tissue here, but the bottom third had ossified. There was actually vital bone formation within the Volumax material. So just like Ossix Plus and Ossix Bone, the Volumax ossifies. Well, that leads to an interesting potential here, right? If we have a case like this where the tissue is very thin, why not put Volumax there instead of a soft tissue option? Why would we do that? Well, remember, it has the potential for some ossification. So here was one of the first times I used Volumax. I trimmed it, I punched it, put it in, did a little more trimming, so I took it out. But you can see the classic pattern of the Volumax texture over here. When we punched it, we could secure it with a healing abutment. Here is it sutured and healing at about 3 months. And when you look at the healing from placement to being restored, there's not much change. It almost looks identical. But that's okay because we had a thin overlying soft tissue, and our goal here was only to maintain the bone. But look at the soft tissue, still looks quite thicker than what we started with. So this Volumax can protect the bone and thicken the soft tissue environment when used over a healing implant site. So it's always in my back pocket. If I don't like the tissue thickness during a routine implant placement, we just put some Volumax over it, whether it's under primary closure or punch for single stage, and we feel very good about protecting that marginal bone. So this was a patient who had a pretty significant abscess. We cleaned it out. I want to show you the contour of the tissues at the time of placement, and there was some shrinkage, good vertical tissue thickness, but it had shrunk. And we know that shrinkage is going to occur irrespective of what graft materials we use. But bottom line, when it came time to place the implant, you can still see some ossix bone healing. But this was the perfect time to slip in a folded, now we have 4 millimeters of Volumax to thicken the tissue. And when we let it heal, you can see a nice, robust, bony healing around the implant. But soft tissue, we've been able to reestablish that facial contour. And the potential is really illustrated here very nicely. This funny patient, this is a woman who moved to Chicago from England. She got married American, but has a lot on her plate. So we placed an implant. This is a profile implant with I don't know if you can tell, a very, very thin concave and atrophied buccal plate, and perfect time to double over a Volumax and put it in. And so she gets distracted. She has to have her spider veins repaired, so she can't come in right away. So she delays it about a month or so, and then she has to go on a safari to Africa, so she delays her return again. And then COVID hit. So by the time I saw her, it was 15 months. Well, I knew I'd put the Volumax in. When we opened it up and put the healing abutment in, this was rock solid. And we actually took a CT before I exposed the implants. And you can see, remember, when we opened this up and placed the implant, it was a paper thin concave buccal plate. But here we have a very, very thick, that looks somewhere between 3 to 4 millimeter thick buccal plate, because all that Volumax ossified. So I think this was an excellent opportunity because of COVID and a couple other distractions to demonstrate the true potential of slipping in Volumax over a thin atrophic area. And here's another case that we performed a ridge augmentation. We used, I don't know if it's necessary to use tenting screws and decortication, but I've done that with my ossix bone augmentations. But we were able to get bone growing to the threads. And when we came to place the implants, these were short implants. I still had a nerve to deal with. I used Volumax to protect it, because with the shorter implants, I'm even more scared, more concerned about early crestal bone loss. And what you can see is this was also a case delayed 9 months because of COVID. When it came time to re-enter, you can see where the Volumax was present over the cover screws, forgive me. When we sent that in, it was very clearly forming new bone over the cover screws. It ossifies. And here it is 9 months later, we're about to perform the uncovery, and you can see almost a linear, curved linear formation of bone where the Volumax was placed. Now we uncover it, and even after it's been restored, that material's still there. So this whole talks about preserving the marginal bone, and this is where Volumax is such a great utility in our practice. it's an insurance policy. When in doubt, if the tissue's thin, if the bone is thin, using Volumex to help insulate wound healing and help form, if not form bone, it protects the bone. And I just want to end on a similar kind of application with Volumex. This was a sister of my best referring man sent to me, and it was a deciduous molar that was removed, and we placed an implant. I tried to cheat to one side where the bone was a little thicker, and sure enough, Murphy's Law, we had some poor bone healing. And I've been told that the bone around deciduous teeth, retained deciduous teeth, has a different quality. Certainly, it had a different quality here. And now, when we look at cases like this happens to be at the time, a 25-year-old friend of my son who came in, and it was time to replace his deciduous molars. When you take out a deciduous molar, you're not going to have these deep defects. You have very, very shallow residual sockets. And so this is an excellent opportunity. You can take a biopsy punch, create a hole in the Volumex, and it serves a few purposes. It's going to fill in and kind of be compressed by suturing into those shallow defects, but it acts as insulation for your wound healing. So as we monitor the healing 2.5, 4 months on the right and on the left, and as the tissue healing progresses, you can see how we had residual sockets mesial to the implant, a little shallow bone, horizontal bone defect distal to the implant on both sides. And as it heals, you can see the crustal bone getting better, not worse. And by the time 12 months comes, you can see the formation of some very healthy, stable bone around these implants. So I think this was a wonderful case to help demonstrate the progression of how Volumex undergoes ossification and perhaps improves resistance to marginal bone loss. And in summary, we've talked about a lot. And we've talked about how we place implants, how deeply we seat them, which implants we use. Smaller diameters may be an advantage in many cases, and roughened implants with microthread and platform switching seems to provide an advantage. And in most patients, a single stage protocol with abutment heights and abutment emergent profiles that are very sensitive to the surrounding tissues, so we don't impinge on the biologic width, help us provide, create implants with healthy healing and stable bone around these implants. If we want to create strategies for future treatment, certainly we want to create thicker implant beds and match the implant placement to the implant qualities. As I said, respect the biologic width, both in height, emergence profile, and we don't want to forget about the crown emergence profile as well. And from a tissue standpoint, to protect the underlying bone, thicken the thinner tissues. You can use autogenous tissue, allografts, or Volumex. Certainly immobile tissue protects better than mobile tissue. And when we have to graft, we want to prevent bone graft failure. So there seems to be a clear advantage to forming as much native bone as possible with the minimum of non-vital residue from other materials. So vital implant bone beds, and protect the healing with good quality, long-lasting membranes such as OsSix Plus. Thank you so much for your kind attention.
Thank you very much, Dr. Barak. Before we will go to the Q&A, I would like to ask everybody here to fill out the webinar survey, which you can access either by scanning the QR code on screen or using the link in the chat pane. Please dedicate only 2 minutes to fill it out for our future improvements. Your opinion is highly important to us and we really appreciate it. I would also like to inform everybody of our next webinars. On May 19th, Dr. Rodrigo Niva and Dr. Francisco Marquesani will be having a clinical discussion about slow resorbing versus fast resorbing biomaterials. On May 26th, Dr. Frederick Kaufman will be talking about minimally invasive techniques for GBR procedures. And on June the 2nd, Dr. Peter Randelshofer we'll be back for the fourth part of a series of lectures to discuss about the enhancement of peri-implant tissues towards a biologically oriented aesthetic restoration at the smile zone. To review the entire list of events, you are all more than welcome to enter the Datum Dental's website. So as promised, let's go over the questions asked by the audience.
Thank you, Chen. We'll start with, can I talk about bone loss on implants that are placed next to each other? What are the things to consider when placing implants next to each other? So early on, when we had non-platform switch implants, the rule of thumb was you wanted to keep the implants 3 millimeters apart or more. And the reason was just what we talked about today, that we know that when we started at the end of implant integration healing and we changed a cover screw or a healing abutment to a prosthetic abutment, the body was going to remodel the bone to help form a biologic seal to protect the tissues. So if you're using a non-platform switched implant, 3 millimeters was the rule. I think we're learning now that as we have implants that are better designed with platform switching, that distance between implants may shrink a little bit, but certainly the closer you get implants to each other, I think in my experience over the years, there is a higher risk of the problems with one implant becoming the problems of both implants. And so distance matters. But certainly when you have implants that are placed next to each other, there is also value in thickening the soft tissue environment as well to prevent that marginal bone loss from even beginning. So I think there's a distance issue. And when you're talking about maybe aesthetic considerations such as papilla fill, we now have evidence that thicker biotypes, thicker tissue thicknesses will fill in the papilla better. But there are some publications out there that will give you guidelines on the proper distancing for optimal papilla fill as well. There is another question. I missed the part on microthreads. Do they make more recession? I think microthreads do not. I think what creates recession is the relationship of the implant to the osseous crest and the marginal bone and the facial or buccal bone thickness. So if you place an implant more facially and you are creating a thinner and thinner bony environment, that is what's going to lead to recession. We now know that bone thicknesses of less than 1.5 millimeters, we'll even say 2 millimeters or less, are more likely to develop gingival recession. And we're talking about bone thickness leading to gingival recession. But the microthreads are, for the most part, considered a big plus in helping to preserve bone. The next question is, do I remove Ossix Plus when I place the implant or leave it in? Always, always, always leave it in. Sometimes it'll move easily. Sometimes it'll already be incorporated into the bone, depending on your timing of reentry. But this material is going to ossify. I see absolutely. It's not like, 20 years ago when I was using Gore-Tex, and when you lifted up the Gore-Tex membrane, there was this weird kind of amorphous tissue underneath that we tended to remove. Right or wrong, we removed it. But with Ossix Plus, you want to leave it in because it's going to form more bone. It's going to ossify. I'd like to know my opinion on my experience using only Ossix bone for crestal increase. Thank you. In my experience, I've really only followed one protocol. Well, I'll specify. If I'm placing Ossix bone in an extraction site, there have been a few cases where we haven't placed a membrane, but overall, I cover it with a membrane for security, and because I flap it, and because sometimes the Ossix bone crumbles and I don't want it to get washed away. But anytime I'm doing a ridge augmentation, and or I'm trying to increase the dimensions of the ridge and the crest, I always, always, always cover it with an OSSIX Plus membrane. And Dr. Nieva has out of the University of Pennsylvania Department of Periodontology, has an excellent piece on how to secure the OSSIX Plus membrane. We don't tack it. We don't suture it because it can tear, but its strength is in its durability and the fact that it can ossify. So there are ways of securing it with a suture that lassos over it, but always use it over any kind of ridge augmentation procedure. So the next question is once more the concept of abutment height and its affecting biologic width. So the studies I've seen have shown that abutment heights that are very close to the bone, less than 2 millimeters, can cause some remodeling of the bone surrounding an implant. And that study I showed from 2014 fascinated me because when you put an abutment on an implant and then all the dentistry after that is abutment level versus implant level, that means you're not disrupting the abutment implant interface. And it seems to me that that would be a safe way to protect the tissues. But in this study, if you trust their results, they reported bone loss if they used too short an abutment height. That certainly fits in with my clinical experience of placing healing abutments too close to the bone or seeing crown contours too close to the bone and getting that remodeling. So I think the takeaway here is that you want to contour your abutments to have some distance away from the surrounding bone, especially if these implants are sunk. You know, we're not dealing with perfectly flat ridges, right? They're not a floor, they have heights, and sometimes the bone is higher on the mesial if you're behind a posterior tooth, or there's going to be some buccal atrophy, and unless you're using a profile, you have to sink these implants. And when you sink them, now you have to bring an abutment up and over that taller bone. So I think that it's about abutment height, but it's also about abutment contour and respecting the surrounding bone. I hope that answers your question. Do I use sedation for surgeries? Well, it's a little off topic, but sometimes we do. I will tell you in our practice, the vast majority of patients are treated either under local or local plus nitrous oxide sedation, but we do offer deeper sedation. Is it okay to completely cover the implant with OSSIX Volumax, completely submerged? In other words, two-stage. So I guess where we use, in my practice, where we use Volumax is more to thicken tissues, either lateral to an implant, so on the buccal or lingual or palatal, or sometimes both. We'll slip in a little bit on each side of an implant if it's a narrow ridge. The only time I'll place Volumax over an implant is if I'm going to, well, it's not over the implant because I'll do single stage and punch it. I don't want to have to deal with chipping away bone from ossified Volumax over the implant. It is an option. It is absolutely an option, but it makes for more work. What is my opinion for the outcome of BioOS if mixed with autogenous versus OSSIX bone mixed with autogenous? So I'm not going to give you the answer you want because I never mix OSSIX bone with autogenous bone. I think you can create a good volume of ridge increase with both BioOS and autogenous bone and OSSIX bone. But here we kind of slip into that argument of function versus volume. Certainly I want volume, but if I want to have tissue surrounding an implant immediately against the implant that is native bone, vital bone with a blood supply and cells that can react to the challenges, then I'm going to put OSSIX bone against the implant. If there's I guess there might be some who might argue for BioOS outside the OSSIX bone, but honestly, I gave you examples of what a wonderful potential for building volume can be accomplished. You know, the potential's there, and you can accomplish a lot of volume increase with OSSIX bones. So I don't even know if you need the BioOS with it. Is OSSIX membrane hard or soft? So the OSSIX membrane start when it's dry, it's a little stiff. When it's moistened with sterile saline, it's very, very flimsy. It'll wrap around your instrument, drapes down very easily. The strength is that it lasts a long time and it ossifies. I don't want to even call it a weakness, it's just a condition of OSSIX Plus. Because it's so good, you have to forgive the fact that you can't tack it. So you have to secure it. 99% of the time, I don't secure it. I tuck it under tissues, and it's rough, it holds its position. But there are times, such as a ridge augmentation, where you want to stabilize it with a lasso suture, but it is not hard. It's soft once moistened. And I'm going to submit to Chen for the next question, because it's who distributes OSSIX products in Canada.
Yes, we will. Yeah, we will contact the person who asked for it,
Okay.
and we'll give you the details of the local distributor in Canada. No problem about that. Thanks for that. Thank you.
You're welcome.
All right, that was the last question. Dr. Barak, with that, I would like to thank you so very much for your time, effort, and professional input. And thank you, everybody, for joining us. And I hope to see you all in our next events. Thank you, everybody, and have a great day.
Thank you so much.